Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Okay, let's unpack this. We are diving deep today into a class of pharmaceutical agents that they might feel like a relic of medicine's past.
They really do.
But they remain one of the single most dangerous substances in modern toxicology. We're talking about cyclic antidepressants, or CAs. For decades, starting way back in the late 1950s with imipram, and right through the 60s, 70s, and 80s, these were the definitive treatment for major depression.
They were the only game in town, really.
Right. They reigned supreme until, the SSRIs came along and gave us safer options.
That history is crucial, absolutely. But the current relevance is what dictates this deep dive. Despite being pushed aside for depression, CAs are still widely and effectively prescribed today.
For a huge range of things.
A massive range. We're talking chronic nerve pain syndromes, prophylactic migraine treatment, even nocturnal enuresis in kids, and some forms of OCD. They are present in almost every hospital formulary and countless medicine cabinets.
So they're everywhere.
Exactly. And our mission today is focused entirely on the core threat these drugs pose, which is their low therapeutic index.
Think of it as a terrifyingly narrow safety margin.
A very narrow margin. You do not need a massive overdose for toxicity to become lethal. A small spike in serum concentration can cause catastrophic, rapid toxicity.
That's why they're still so dangerous.
This is precisely why, even now, CAs are among the leading toxic substances associated with fatalities reported to poison control centers worldwide.
So we're going to pull apart the deadly pharmacology, understand the specific high-yield clinical signs you must look for, and then detail the specific life-saving strategies you need to deploy immediately. This is not a history lesson.
No, this is a guide to avoiding catastrophic failure.
Okay, so let's start right where the danger begins, that narrow margin. You said people can go from a therapeutic dose to mild toxicity without even taking an overdose. That just sounds wrong.
It seems counterintuitive, I know, but it comes down to individual biochemistry. CAs are metabolized by specific enzymes in the liver, most notably the CYP2D6 system.
And not everyone's system is the same.
Not even close. Human genetics are wonderfully variable. We have whole subsets of the population who are genetically predetermined to be poor metabolizers.
A poor metabolizer? What does that mean in practice?
It means your body processes the drug much, much slower than average. So a standard therapeutic dose, which is safe for most people, it builds up. It accumulates rapidly in your bloodstream.
So you're essentially creating a functional overdose, even though you took the pill exactly as prescribed.
Precisely. It's a metabolic bottleneck, and the drug just backs up in the system.
But it's not just your genes, right? It's what else you're taking.
Absolutely. The problem is instantly amplified if you co-administer CAs with other medications that inhibit that same metabolic pathway.
Or even drugs that just have similar effects.
Exactly. We're talking about common things like certain antipsychotics, some potent SSRIs, or even over-the-counter antihistamines. They're all competing for the same machinery, driving up the free concentration of that CA to toxic levels.
This is where it gets really fascinating because we assume the biggest cardiac threats come from a massive acute overdose. But the sources highlight this paradox regarding torsades de pointes.
Right. This is one of the most interesting parts. What's truly wild here is that torsades de pointes, that chaotic, twisting form of ventricular tachycardia, is actually seen more commonly with therapeutic levels of CA.
Wait. More common with the prescribed dose than in a massive overdose?
That's right.
How is that even possible?
The leading theory is It's a bit backwards. In a massive acute overdose, the anticholinergic effects of the CA are so profound that they cause this vicious, rapid sinus tachycardia, a very fast heart rate.
Wow.
And that extreme speed actually has a sort of protective effect on the heart's recovery phase. It shortens the risk of QT prolongation, which is what Torsades needs to get started.
So the side effect accidentally protects you from another deadlier side effect.
In a way, yes. But when you're at therapeutic levels, you might not have that protective fast heart rate, leaving the heart vulnerable.
So the takeaway for a clinician is what?
The clinical takeaway is crystal clear.
Wow.
CAs should absolutely not be initiated in any child with a resting QT interval greater than 450 milliseconds or anyone with a known bundle branch block. You are setting them up for a critical risk.
That immediately changes the conversation from what did the patient take to who is the patient. The baseline cardiac status is everything.
It's paramount.
So let's move from that narrow margin into the core mechanism. When CAs turn toxic, what is the one thing that's most likely to kill you?
The key is pharmacological non-selectivity. CAs are not refined tools, they're blunt instruments.
So they do their job, but they cause a lot of collateral damage.
A lot. They inhibit aminobutyrin reuptake for the antidepressant effect, but they simultaneously disrupt nearly half a dozen other critical receptor systems.
But the undisputed king of death, that's the heart's electrical system.
Yes, exactly. The most important factor contributing to patient mortality and overdose is sodium channel blockade. This is the cardiac kill switch.
So what does that mean physically?
CAs physically inhibit the rapid influx of sodium ions through the voltage-gated channels in the his Purkinje cells and the ventricular myocardium.
And if sodium can't rush into the cell, the entire electrical depolarization, the firing of the heart, is just massively delayed.
It's crippled. You get delayed depolarization, impaired myocardial contractility, so the pump gets weak, and these wide complex conduction abnormalities.
Which, on an ECG, looks like disaster.
It translates to profound QRS widening and life-threatening hypotension and arrhythmias.
So sodium channel block is the central deadly mechanism, but the patient who overdoses looks like a complex mess. What are the other toxicities at play?
There are 4 major side effects that contribute. First, potent anticholinergic toxicity. This is the classic mad as a hatter, blind as a bat syndrome.
Dry skin, dilated pupils, fever, urinary retention.
Slowed gut motility, sedation, and severe delirium.
Yes, same.
Second, the antihistaminic effects. Potent inhibition of histamine receptors leads to profound sedation, sometimes coma, and is thought to contribute to the seizure risk.
Okay, 2 down.
Third, alpha-adrenergic antagonism. Blocking peripheral alpha receptors causes massive peripheral vasodilation.
So the bottom just drops out of the patient's blood pressure.
Right, which makes the hypotension from the weak heart pump even worse. And finally, we see evidence of GABA receptor antagonism, which removes the brain's main inhibitory brake,
Leading directly to seizures.
which we see in about 10% of CA overdoses.
And we need a specific warning here for the atypical cyclics, like amoxapine and maprotilene. They're a different beast.
They absolutely are. These are tetracyclic or dibenzoxazepine drugs. They're structurally distinct, but they share the same cardiotoxicity.
Yeah.
The key difference, though, is that they are associated with a significantly greater incidence of seizures.
And the warning sign isn't always there.
That's the critical part. For amoxapine, seizures can occur even without the QRS whitening that we usually use to predict seizure risk. You cannot rely on a clean ECG to rule out a seizure with these agents.
That is a life and death distinction. Okay, let's pivot to how the body handles these drugs, which explains why our standard detox methods are totally useless. Tell us about the toxicokinetics.
Right. In an overdose, CAs present unique challenges. Because of the anticholinergic effect, the gut slows down, so absorption is already prolonged. But the real issue is distribution.
Where the drug goes once it's in the system.
And CAs are incredibly highly lipophilic. They love fat and tissue. This gives them a massive volume of distribution, sometimes 50 liters per kilogram.
That number is enormous. For an average person, you're saying the total space the drug occupies is vastly larger than all the water in their body?
Correct. They distribute extensively into tissues, the heart, the brain, the liver. The drug concentration in the tissue can be 10 to 50 times higher than in the blood plasma.
So only 1 or 2% of the total drug is actually in the blood.
At any given time, yes. Maybe 1 to 2%.
Ah, and now I see the implication. If 98% of the poison is locked up in the tissue, then any method that relies on filtering the blood, like hemodialysis,
Is entirely futile.
you'd be filtering 2% of the problem.
Exactly. Due to that immense lipophilicity and high protein binding, enhanced removal techniques are just ineffective. It's like trying to clean a sponge by repeatedly dunking the string it's tied to into water.
The contamination is locked in the sponge.
It is. And just to offer a fascinating, if a bit morbid, insight for you, CAs are famous for post-mortem drug redistribution.
What's that?
When a patient dies and the heart stops pumping, the drug, which was tightly bound in the tissues, starts leaching back out into the blood. This causes plasma concentrations to jump 10-fold to 50-fold after death. It changes how forensic toxicology works entirely.
That is wild. The body's chemistry keeps going, even after everything stops. Turning to the live clinical presentation, you said this toxicity is rapid. What does that critical 6-hour window look like?
We stress to every clinician that most fatalities occur in the initial hours, often before the patient even gets to the hospital.
So when they first come in, what are we seeing?
The most common initial findings are simple: CNS sedation and sinus tachycardia.
But that can change quickly.
The deterioration is often unpredictable and lightning fast. Within 6 hours of a major ingestion, that patient can rapidly shift into severe toxicity. Deep coma, profound hypotension, wide complex tachycardia, and generalized seizures.
But if you can get them through those first few hours,
The prognosis improves dramatically.
since we can't wait for lab results because they're slow and don't correlate with severity, what is the single most important diagnostic tool we have right now?
The electrocardiogram, the ECG, is the best, most essential screening diagnostic test. Full stop. Most major cardiotoxicity will show up within 2 hours of ingestion, and the ECG is instantaneous.
And what are you looking for on it?
You're looking for prolongation of the PR, the QT, and especially the QRS intervals.
Give us a critical number. What QRS measurement screams danger?
QRS widening is the gold standard. A QRS duration greater than 100 milliseconds is already associated with a 33% chance of seizures.
Okay, 100 is the first red flag.
But if that QRS interval pushes over 160 milliseconds, the risk of life-threatening ventricular dysrhythmias jumps to 50%. That 160 threshold is the point of maximal alert.
And there's a visual sign too.
Yes, and you must look for the classic sign: the right axis deviation of the terminal 40 milliseconds of the QRS complex. You see this best as a tall terminal R wave in lead AVR that is greater than 3 millimeters.
Wow.
That specific finding is highly predictive of seizures or fatal arrhythmias, sometimes even before the QRS hit that 160 mark.
That specific visual detail is what separates the experts.
Okay.
Okay, we have a rapidly collapsing patient. The ECG is screaming, sodium channel block, and we need to reverse it now. What is the absolute non-negotiable mainstay of therapy?
The immediate goal is reversing that sodium channel block in the cardiotoxicity. The absolute mainstay is serum alkalinization combined with sodium loading, and you deliver that via hypertonic sodium bicarbonate.
This isn't just about neutralizing acid, it's a tactical maneuver. It's a 1-2 punch, right?
It is. The first punch is the sodium loading. We hit them with 1 to 2 milliequivalents per kilogram IV boluses. This massive infusion of sodium just overwhelms the channels being blocked by the CA.
You're forcing the electrical conduction to normalize?
Right. The QRS complex should start to narrow. The second punch is the alkalinization. By raising the serum pH, our target is 7.50 to 7.55, we shift the equilibrium of the CA molecule.
How does that help?
CAs become less ionized in an alkaline environment. This decreases the drug's binding affinity for the sodium channel. You're effectively reducing the free active drug concentration near the heart.
So you weaken the drug's grip while overpowering the blockade with sodium. But what if the patient is hypotensive, which you said is the most common cause of death?
We start with isotonic crystalloids, but often the vasodilation is so severe that you need powerful direct support.
What's the vasopressor of choice?
If the hypotension is refractory to fluids and bicarbonate, you have to bring in the heavy hitters, and norepinephrine is widely considered the vasopressor of choice.
Why norepinephrine specifically?
It's a potent alpha agonist, and because the CA itself is causing massive peripheral vasodilation by blocking alpha receptors, norepinephrine helps counteract that mechanism directly.
And for refractory ventricular dysrhythmias, bicarb first, then what?
After bicarbonate, the preferred second agent is lidocaine, a class AB antiarrhythmic. It successfully competes for those sodium channels, helping to stabilize conduction, but crucially, it doesn't prolong the QRS interval further. It avoids worsening the core toxicity.
And for torsades.
If you see that twisting pattern of torsades de pointe, which remember is more common in chronic toxicity, you treat that immediately and specifically with at least 2 grams of intravenous magnesium sulfate.
And for seizures, which only worsen the acidosis, we stick to the basics.
Yes, benzodiazepines are the first-line anticonvulsants, lorazepam or midazolam. You only escalate to things like barbiturates or propofol if the seizures are refractory.
Now, you said there's a list of things we absolutely cannot do.
We must issue a critical warning. This is perhaps the most important set of facts next to the bicarbonate. There is a precise list of medications that are absolutely and severely contraindicated.
Because they'll make things worse.
They will guarantee a worsening of toxicity or precipitate fatal complications. You must avoid all sodium channel blocking antiarrhythmics. That means class A and IPUAC agents. Avoid class 3 antiarrhythmics as they prolong the QT interval.
And what about CNS agents?
Specifically, avoid 3. Do not give phenytoin as it may worsen sodium channel blockade and CNS toxicity. Do not give flumazenil as it dramatically risks precipitating generalized seizures. And absolutely do not give physostigmine due to its risk of seizures and cardiac toxicity, including asystole.
That list of do-nots is as vital as knowing what to do. Okay, finally, intravenous lipid emulsion, or ILE. Where does this novel last-ditch effort fit in?
ILE is reserved as a third-line intervention, primarily for refractory cardiac arrest or shock where everything else has failed.
And how does it work?
Because CAs are so incredibly lipophilic, the proposed mechanism is the lipid sink effect. The intravenous fat globules essentially act as a giant sponge.
Soaking up the drug.
Exactly. Sequestering the highly lipophilic CA molecules in the bloodstream, pulling them away from the sensitive receptor sites in the heart and brain. There's also some thought it provides direct metabolic support.
But it's not the first thing you reach for.
The critical note, which cannot be overstated, is that ILE is a third-line agent and must never delay the immediate administration of that life-saving sodium bicarbonate.
So we've covered the history, the terrifying mechanisms driven by that sodium channel blockade, the high-yield markers on the ECG, and the central role of serum alkalinization.
And remember the critical disposition. If a patient is symptomatic, especially if that QRS crossed the 100 millisecond threshold, they must go to the ICU. They require continuous cardiac monitoring for a minimum of 24 hours after all CA-specific therapy is stopped and toxicity is resolved.
Only asymptomatic patients can be cleared after 6 hours.
With normal ECGs and vitals, yes.
That 24-hour post-resolution mark is the safe landing zone. And here's the provocative thought we want to leave you with, building on the structural differences we discussed. If amoxapine and meproteline drugs with only slightly different chemical structures can induce a significantly higher incidence of seizures than traditional CAs, what subtle, almost invisible chemical differences in other common medications might be unknowingly predisposing vulnerable patients, like those poor metabolizers, to rare toxicity or death?
The learning continues long after the first deep dive.
Thank you for joining us for the deep dive. We'll see you next time.
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.